Those of you who are joining now, you're shocked that we're starting on time. Yes, we are. Miracles do happen sometimes. Very, very excited for today's session because as you guys have come to know, those of you who are logging on, I get to co-discuss with Lyra, and these Friday sessions have really been the sort of iteration of the Thursday sessions where more seasoned and entrenched CP Solvers team members take Reza's big shoes. He's able to join us occasionally, but when he can't, it's very, very easy to search the CP Solvers Academy and be like, well, who is a future Reza? Uh-oh. Sorry, one sec, y'all. I don't know if you can still hear me. My entire screen went blank. Yeah, I can't see everybody. Yeah, and there's no doubt about it. Lyra is a future Reza, and I think he'd be the first to say, and I certainly acknowledge that the future with her driving is way, way brighter. Yeah, I don't think you need an introduction, Lyra. I think what you've done in the space is unreal. And a little bit more of a personal note, when I look back and I remember my early residency days, I think we have a lot in common in that sense. I was absolutely addicted to clinical reasoning, as you are. If Lyra is not on one of our internal academy sessions, I guarantee you that either something really, really serious has happened or that she's working and cannot join, which is a feeling I deeply resonate with. And I think the only challenge that you'll have in your career, Lyra, is if and when you get full, how you manage the learning that you do. But it's such a treat to have you here. And I should say though that I think all of us get lulled into the sense that you are on your way to be a clinical reasoning monster and educator. But I think what goes on behind the scenes and how you foster community and help people and hop in, describe and do teaching points and welcome the new academy members is unreal. And that combo of IQ and EQ is a really special one. So I think no one better fitting to hop into Reza's shoes today. I actually chatted with him and FaceTime with him 30 minutes before, and he was very, very thrilled that you were taking his seat. So let me hand the mic to you to say hello, and then we'll introduce the rest of this party.
Yeah, hi everyone. My name is Lera. I'm now a first-year resident in Russia, internal medicine resident in my cardiology rotation right now. We just got back like 30 minutes ago. Very, very excited to co-discuss again with Dr. Rabih because the first time was a blast, an absolute blast, and the second time will be no less, I'm sure, because the Alec is presenting, and I've been really lucky to present some of Alex's cases that he shared with me, and I get a sense like what he keeps in store for us.
Oh my gosh, you couldn't have said it any better. Alec, CP Solvers legend, shaping the landscape of CP Solvers for many, many years now. We've missed you in this space and very, very excited to have you back. I'll hand the mic to you to say hello.
Hi, thanks so much. Yeah, you guys are always too kind. If you're not sure, like if you want to present a case or how much you want to be involved, I'll tell you that the first VMR I presented was VMR number 12. I looked it up. That was in March of 2020. So not quite single digits, but close. And today we're in the like mid 1700s. So everything's full circle, and like no matter where you are in your training, you can always continue to learn and to grow and to be passionate or have your interests come and go. So make the space of what you want of it, but always honored to be a part of it. And I'm thankful for Robbie and everybody that has just made this amazing community for all of us. So thanks for having me.
Very, very excited to have you here. Oh my gosh, that's crazy. VMR number 12. Wow. Wow, time flies. Um, we are honored to have the Zachariah Squared combo anchoring this, and maybe I can hand the mic to the OG, followed by Zachariah E.
Hi everyone, I'm Zachariah G. I'm very excited for the case. I can tell you that when Lera was studying med school, I was like, wow, I've got to start putting up my socks because I'm a few years more senior to her supposedly, but it didn't feel like that. So really excited to learn from her and from Ravi and go for the case.
Hi everyone, I'm Zachariah E. Also excited for the case and very excited for this weekend. We have a very exciting lineup in Cape Town. We have the Cape Town Marathon
Ooh,
happening this weekend. And if Ravi will allow me just for 30 seconds, I just want to share
yeah.
my
Sounds like
screen, just something non-medicine related. The Cape Town Marathon is apparently
wow.
one of the most scenic marathons in the world to run. So I invite each and every single one of you to come and see Cape Town. This is some of the views through the run.
Amazing.
It's spectacular. And I think next year is the move towards making it Africa's first major marathon.
Wow.
So hope to see all of you next year. I think it's happening next year in May. So I'm
Amazing.
inviting all of you, all the CP Solvers members and the whole community who are watching on YouTube and everywhere. Um, we get together commonly under the common banner of medicine, but why not? We can run together.
No, you sold me, my friend. Yeah, nothing I enjoy more outside of medicine than going for a run. So that looks absolutely spectacular. Amazing. Thank you for that. All righty, let's get this party started. Alec, mic to you.
Okay. All right, let's get started with Alcott one. So this is a 60-year-old man, and he is presenting with a growing chest mass. So just again for the scribe, 60-year-old man presenting with a growing chest mass. So I'll tell you, he says about 5 years before the current presentation, he fell at work. He works in construction and hit his chest on a scaffolding board. And he says ever since then, he's had a little bump on his chest. And it would sort of like wax and wane in size, but it was never really all that bothersome or limiting to him. He would just sort of put an ice pack on it when it bothered him, mostly if he just like bumped it on something. But it never fully went away. And he says over the last 6 months, the mass has gradually increased in size. He's lost 15 pounds over these last 6 months. And he's occasionally noticed some trouble breathing, particularly when lying flat. But sometimes as well has had a little bit of difficulty swallowing certain harder foods, but not always, and no real issues with liquids. But he hasn't noticed any fevers, chills, night sweats, any cough, any nausea or vomiting, no belly pain, no other GI or GU symptoms, no lower extremity swelling, any neurologic symptoms, or really anything else. And honestly, he tells you he wasn't really all that bothered by it, but his friends and his family kept telling him that they were more concerned about how big it was getting. So they told him to come in and get evaluated. So I'm going to stop there and just get your reflections.
Gosh, what a start. Not the least bit surprised. Lyra, what are you thinking?
Yeah, I don't have robust illness scripts for chest wall masses. So I think just approaching from like 10,000 feet view, I would like to understand what's the cause of this mass and basically what is comprising this mass. But also then investigate for some consequences of this mass. And for the first question, I think we can go anatomically to just understand what kind of tissue is comprising this mass. Is this just a skin? Is this subcutaneous fat like lipoma? Is there something musculoskeletal like osteoma or potentially like osteal scar formation from the fall that the patient had? Or is there more deep structures like some muscular potentially structure or vascular or potentially even deeper like lung mass that is now coming out from inside to outside. And yeah, as for consequences, I think I would love to know if there's any sign of mass effect of this chest mass. And I think in close proximity to the organs in the chest wall that we have, I would be worried most about the respiratory system of the patient. Is there some evidence of stridor? Is there some evidence of respiratory distress, but also vascular compression, like potentially superior vena cava syndrome or compression from other locations? And here the patient actually has some difficulty breathing when lying flat. And I wouldn't be too quick to attribute this directly to the mass, because it could be, but I wouldn't expect orthopnea to be a prominent feature of chest wall mass. usually when we think of orthopnea is either the most common cause being the left heart dysfunction, causing pulmonary vascular congestion, but also less common causes, mainly the problem with diaphragm. And here we can also see the potential indication of some muscular process going on with the patient complaining of dysphagia. So I think I would be most worried about consequences, also distal consequences of potentially this mass, like not directly from compression, but also maybe on molecular level, causing some muscular issues and muscular weakness. Yeah.
Yeah, absolutely superb. I have nothing to add to that, Lyra. I'm not the least bit surprised by that. And I remember your reactions to the conversation we had a long time ago about weight loss and how articulating the concept that weight loss is almost always associated with a systemic disease. The idea being something focal is usually not of significance enough to consume the entire body's weight. Um, and so maybe I can just bring that topic up, but pass that to you to reflect on about how you're incorporating a decent amount of weight loss that this patient is having. How does that help you?
Yeah, I remember that usually we associated weight loss with some systemic disease, with single exception for local disease being in a very targeted strategic location, like mostly from the proximal GI tract. And it could be the issue here because we don't know the true extension and depth of this mass, because it potentially can go as deep as proximal GI tract. But also, at least for now, I'm more worried about the systemic disease causing weight loss. And especially, yeah, we have dysphagia, which could indicate that we have a local proximal GI lesion. Yeah, so I think both options are still possible here.
Yeah, I agree with you. Yeah, I think that, at the end of the day, when somebody's telling you, hey, there's something right in this specific part of my body, and you're like, oh, okay, let me go look over there. But you also see at the same time that their whole body has shrunk. You should really emphasize the disconnect between those two things. And I think this disconnect is best emphasized in the condition that we know the most to cause weight loss, which is cancer. And a really fascinating study published in the New England Journal of Medicine 2 or 3 years ago illustrated that there are essentially two fundamentally simple possibilities for patients with cancer to have weight loss. Either they had metastatic disease or they had involvement of their upper digestive tract. There are very, very few exceptions to this rule. And I won't discuss them now, but I want you to know, Lyra, that part two of that conversation is that there are exceptions. And we'll try, if it comes up in this case, to explain why that's the exception and go from there. But the exception is meant to be an exception, meaning that you should first track whether this disease is pseudofocal, meaning that it appears to be focal, but we're going to later learn this patient's abdomen is studded with the same disease that's in his chest. Or that actually, as you said, that the dysphagia represents aerodigestive involvement. And so I just wanted to take your approach and completely agree with it, co-sign it. And then when merging it with the weight loss, creates two parallel processes. One is this is just the tip of the iceberg and there's disease everywhere. Or two, the involvement of the dysphagia is of serious significance, maybe more so than the patient may be telling us. And only after we exonerate those two will we begin to solve what kind of focal diseases result in widespread weight loss. And I think that'll be the path that we try to follow. We'll see where Alec takes us.
Okay, amazing discussion, both of you. So just a little bit of the background. So this patient has a history of tobacco use disorder, about 40 pack year history. Doesn't have any surgeries in the past, not taking any medications, no allergies. In regards to family history, he has cancer in his brother and multiple relatives on his dad's side, but wasn't really sure what type of cancer, the age that they had cancer. In regards to social history, he worked in construction until recently. He's lived in Houston all of his life, was previously incarcerated, but been out of jail for about 10 years. Not currently sexually active, no prior history of STIs, and he lives with his family. And just to confirm, I've changed all this for privacy information, but just to be sure everyone knows. And yeah, I'm going to stop there. get your reflections, and then I'll give you the exam after that.
Pro move. Thank you for that. All right, Lera, what are you thinking now?
Yeah, I think I'm still considering all the other possibilities that we discussed before, and basically the absence of history doesn't move the needle too much for me. Again, just we have some indicating risk factors in the form of smoking that we could potentially attribute to higher likelihood of cancer related diseases rather than infection or autoimmune inflammatory conditions here or non-inflammatory conditions at all. But yeah, I think I would still like to keep the differential broad.
Yeah, I'm right there with you. I think we glossed over this because there was a lot to digest in the first talk, but how are you incorporating the trauma history here? How is that playing in your mind?
Yeah, I think since it was really a long time ago, like 5 years prior, before the patient started experience new changes with this chest wall mass, I think, especially with the history that there was a small bump developing after the trauma, but there is a new change in the symptoms and in the mass that the patient experiencing right now. I think there is a potentially acute and chronic process here, and it's not, to me, it's not crystal clear whether it's progression of this chronic process that this patient has had, or is there some new associated disease developing in the vulnerable space that this patient is now seeing.
Yeah, no, I'm right there with you. I think you're trying to when you were trying to connect two things, you use the 3C mnemonic is when you're trying to connect A and B, for example. So is A causing B, which a hematoma after trauma would be an example. Is A contributing to B? So if a patient has Behçet's disease and they get trauma, the trauma superimposed on Behçet's disease causes a ulcer. And then the last C after causal contributory is coincidental, meaning it's true, and unrelated. And I will tell you that the wisest approach here is to assume that the trauma merely attracted this patient's attention to an otherwise coincidental process. And the reasoning and the logic for that is actually very simple. Of the millions and billions of people who have trauma to their chest wall in a manner like this, none of them develop a process that invades over 5 years, unless that trauma had a unique exposure of this very small set of organisms. But that probability is certainly acknowledgeable. So I think that yes, the trauma could be causal, it could be could be contributory. But I think the safest hypothesis is to say, I'm glad the patient had this mild trauma to direct his attention to a crystal clear series of events. And if he hadn't had that trauma, maybe he wouldn't have realized the slow evolution of this process. So yeah, we'll see which one of the 3 Cs applies. And if this patient has a specific bug, it certainly is causal. If there's a vulnerability in the bone and the patient had trauma there, maybe broke it, or but my operating hypothesis is coincidental because that keeps it open to many, many other alternative options. And I, like you, whenever you're given background information on a patient, when the foreground is murky and you're not really sure what you're dealing with, the background information sits to the side until you crystallize the current problem. So if we later learn that he has cancer, then all of a sudden we'll ask ourselves, wait, is there a hereditary process here with such prominent family history? But right now, the differential diagnosis is so broad, it's hard to take advantage of the context with which we're in, but we can certainly revisit it in the future. All right, Alec, Mike, to you.
Okay, awesome. So let me give you the exam. So the patient was afebrile, temperature was 98 Fahrenheit or 36.7 Celsius. Blood pressure was 117/74. Heart rate was 95. Respiratory rate of 20. Saturating 99% on room air. The BMI was 27. So generally, he wasn't in any acute distress. Cardiac exam was normal, no murmurs, no appreciable JVD. The lungs were clear. There was no wheezes or rales. There was equal chest rise bilaterally. He wasn't having a hard time breathing. The abdominal exam was benign. There was no appreciable organomegaly. There was no lower extremity edema. His neuro exam was completely non-focal. In regards to his chest, He had a large anterior chest wall mass projecting from the lower neck down into the chest with some overlying dilated vessels. It was very mildly tender to palpation, but there was no significant warmth or erythema. Let me share a picture with you. Okay, are you able to see that? And I'm just going to leave that there, and I'm going to stop here and sort of get your reflections at this time.
Yeah, go for it, Lera. What do you think?
Yeah, really interesting situation. At least for now, I'm not confident enough to say what the mass is potentially made of, because at least it looks deep to me, because there are overlying vessels, which implies that there is potentially a deeper process going on that is pushing all the dermis with the vessels and hypodermis up and causes the vessel dilation. And yeah, I'm not sure what to make of more.
Yeah, I mean, I think it's shocking in terms of its size and how alarming it is. And I think the first thing I'm reflecting on is what the patient's relationship is with this entity, because he seems to have made light of its significance, but the rest of us have our jaws on the floor. And so I think that's going to be a really important aspect, to be thoughtful about how you care for this patient, to acknowledge the difference between your jaw being on the floor and this patient. This response being, I'm here because my friends advised me to be here. But I think it does tell you just how indolent and long-standing this has been, that the patient's mind and body is used to it. And I think it would be impossible for it to get to this size without that being the case. And yeah, I agree with you. I think its impact on the surface is readily apparent. The question is, well, how deep does it go? And I think where does it originate? I think we now know that the probability that it originates in the skin is low, but anything deeper within is very fair game. Um, and it's amazing to see, if you just like look at the health of his skin and the health of anything else, it looks fine. He doesn't seem to be somebody who's afflicted by a chronic disease based on the his girth otherwise and the health of his skin. One reflection we can go back to is, can you creatively imagine how this process may be related to orthopnea? What do you think?
Yeah. I usually think of orthopnea either as left ventricular dysfunction or some diaphragm problem, either intrinsic to diaphragm or increased load to the diaphragm, either from upside from the chest wall, like in COPD patients, or from downside from the abdomen, like in patients who are very obese. And here I would expect that the mass is potentially, since it's really large and it's really chronic and we don't know the extent of the mass, I would expect it to be causing some potentially mass effect, especially when the gravity is working for the mass when the patient is lying down. Yeah.
Yeah, I completely agree with you. I think that the sheer effect of the mass is very plausible. I think if you take the vessels into account as well, the compression on the airway and the effect on the diaphragm are noteworthy. In parallel, you make note of the fact that his external jugular vein is engorged. And if you look closely at his left upper extremity, at his wrist, he's got some engorgement then. And of course, that may be physiological gravity dependent engorgement, but it does make you wonder whether there's a venous compression in his chest. The counter argument to that, of course, is that his face doesn't seem to be plethoric or flushed, nor do his arms be edematous. But the slow compression on the superior vena cava may have created enough collaterals to minimize the impacts on the soft tissue surrounding it. So I'm intrigued by the vessels, because they may imply that the process itself is inducing angiogenesis, or angiogenesis may be a physiological response to deeper vein compression. And the latter hypothesis is way more morbid, and I think really increases the concern beyond already the size of this mass and the presence of dysphagia, that there might be compression of vital mediastinal structures. Um, Lyra, if you could sort of play the exercise of what you think, what you predict the major momentum gathering test will be that really helps you take the biggest step forward, what might you guess that test will be?
I think at this stage, I would want to see imaging to understand where this mass is coming from.
And what might you order if this patient is showing up in your cardiology's rotation for a magical reason? What do you think you would order? What kind of imaging?
Yeah, I think I would go with the CT scan with contrast.
Yeah, beautiful. Yeah, I mean, this illustrates to you the principles of why we give contrast in the chest. You give it for PE, you give it for pleural disease, and you give it for mediastinal processes. And I suspect that that's where this mass is extending to, or even originating from. Awesome. Yeah, and I think the labs will help decorate the signature. So if this is an invasive chest wall process with deep neutrophilia or with eosinophilia or with liver involvement, I think that'll be illuminating. But wrapping our fingers around this process visually with the CT will probably be a really momentum gathering step. But that may take some time. So we'll see how Alec has his case prepared for us. But I, like you, anticipate that to be the test that I'm itching to hear about. All right,
Okay.
Alec, that's you.
Yeah, thank you both so much. Awesome discussion. So let me give you some labs. So for the CBC, the white count was 6.5 with a normal differential. The hemoglobin was 10.4 with an MCV of 93, and the platelets were 218. For the BMP, it was completely normal. The creatinine was 0.8, the calcium was 9.6, everything else was normal. For the liver chemistry test, the protein was 7.9, the albumin was 4.3, and the AST, ALT, T-billy, and alk-phos were all normal. The PT and PTT, INR, normal. HIV was negative. Hepatitis B and C was also negative. He had an EKG demonstrating normal sinus rhythm. I'm going to share my screen again with you. Okay, hopefully you guys are able to see this. I'm going to play a video for you. Let me know if it's not playing.
Now we see it.
Then I think I'll change windows here in a second and it'll run through again. Okay, and then I'm going to share a still image of the CT scan in the sagittal view. And yeah, I can, if you guys want to interpret it, you can, or I can give you the read, whatever you would prefer. And if you want me to play the video again, I'm happy to. Just let me know.
Oh, this is incredible. Why don't we just take a crack at seeing how much we can get out of it, though? I don't think I can come even close to a comprehensive read. But Vera, what observations did you make?
Yeah, I see mass, which looks like, at least based on the density of the tissue, it looks like it's soft tissue originating mass. And I'm not sure whether inside the mass it's contrast extravasation or maybe calcifications. But yeah, potentially. And we also see the consequences of the mass on the trachea in the form of compression. And now we potentially know why the patient has orthopnea, because the mass is compressing the trachea. And as we discussed, like the stress test for the lower extremities, lower respiratory tract is exertion, but the stress test for upper airways is laying down. So with this in mind, I think, yeah, really interesting that I'm now more inclined towards thinking that there is a local process causing both weight loss and dysphagia rather than systemic features of the disease. And just based on the size of the mass and absence of other features on the labs or on the imaging, at least that I was able to spot, I think this is a very localized process to me, which looks just based, yeah.
I'm right there with you, Lyra. Yeah, I think it's absolutely fascinating what this is, and I think you made comment to the. Well, actually, we can just save the labs for a second. Yeah, it was really fascinating to see like what the extent of this process is, and I think its invasion into the mediastinum was apparent. I couldn't even tell if it was invading into the heart or not. I was open to that possibility just based on the views that we were getting. It's certainly compressing the trachea and compressing the esophagus. And I think the question that we're trying to decide is it invading from the chest wall into the mediastinum, or is it invading from the mediastinum out into the chest wall? And I think that was very difficult to try to decipher for me. But I'm right there with you. I think there's no signature of this disease elsewhere. The liver looks great radiographically, and the bones, the skeleton looks great radiographically. So I'm right there with you. I think this is a localized process, and I'm trying to figure out where it's originating from and where it's spread. It's probably very hard to try to tease that out. So very, very curious for the official readout. Like this is a really tricky one.
Yeah, I love that. I had the same question about where did it start? So let me give you the read. Said the lung parenchyma was just had some mild apical emphysema, but there was nothing inside the parenchyma, nothing in the pleura. Bilateral axillary lymphadenopathy. The largest was 3.5 centimeters in the left axilla. There was also multiple left subpectoral lymph nodes. The largest was a little over a centimeter. And they described this as a 15 by 18 by 16 centimeter lobulated soft tissue mass that was centered in the superior anterior mediastinum with scattered foci of enhancement and coarse calcifications that eroded through the sternum and extended into the subcutaneous tissues of the anterior chest wall. The mass extended posteriorly and invaded the first rib. There was severe compression of the trachea at the level above the carina, around T4. And the mass effect on the cardiac pedicle resulted in moderate to severe narrowing of the right brachiocephalic artery and vein, but still appeared patent. There was no evidence of significant collateralization. And the fat planes between the mass and the pericardium and great vessels were maintained. There was also a 3 by 4 centimeter soft tissue mass in the right posterior first rib that was directly extending from the large central mass. And there was extensive anterior chest and lower neck venous collaterals. And I'll post this in the chat for our Zacharias. And yeah, any reflections on the read before I give you any more information?
Go ahead, Lyra. Any questions you want to fine tune or understand better based on the read?
Yeah, I just have a single reflection that it's very interesting how systemically it looks like quite a benign mass, not causing any signature, but locally it's very aggressive and destructive.
Yeah, I think that's the tension, right? I think you've represented the problem so well. There's a mediastinal mass that is behaving very, very aggressively in its consumption of space, but also consumption of everything in its way, by either consuming something or breaking it down. And you can tell it's been there a long time based on its size and based on the venous collateralization, but it makes no effect to the patient's body. So I'm curious, maybe we could just spend a moment. What are you thinking about in terms of how you would treat this patient right now? Anything that you think you would do to support him? And I'm curious what you think the cause of this mass might be.
Yeah, I think that since this patient has a very mass effect from this mass in the terms of dysphagia and also compression of the trachea, I would want to manage those complications first. So potentially starting parenteral nutrition if the patient is not able to eat or has still progressing dysphagia, because the weight loss indicates that likely this is also contributing to the weight loss. Yeah. And in terms of causes, it's really interesting space, something that is very aggressive, has a more like on the side of a chronic course rather than subacute or acute. And it's not very systemically loud. Yeah, I would think I would just go from the basic IMID mnemonic with like infections, considering some granulomatous infections that could cause such presentations. I know I've read a case of coccidiomycosis causing similar mass that is very locally aggressive, but the absence of systemic features makes me really adopt this theory. I know that there are some strains of mycobacteria that can present with just a local mass effect, and that can also be like potentially introduced into the patient's body by the fold that he had in the past. Yeah, in terms of autoimmune and inflammatory conditions, I would be thinking also about some infiltrating diseases, like, but also again, the absence of systemic features makes me doubt this category. And in terms of malignancies and neoplasms in general, I think this is the top on the differential for me right now. And yeah, with the soft tissue density, I would be thinking about in the way of sarcomatous potentially, etiology of the mass. Yeah.
Sorry. Yeah, I'm right there with you. I think that the kind of processes that you seem to have filtered down to is entertaining certain infections and certain malignancies. I think an autoimmune disease is possible, but it would be a stretch. And so I think whenever you see a mass this size, your default hypothesis is malignancy, malignancy, malignancy. And I share that concern. And I think the number of malignancies it could be is not a very large number. And most of them are probably in the category uh, of soft tissue tumors like sarcomas. And I think that's probably the base rate concern for a mass that's this large in this location. It is interesting to sort of have a quick conversation about when tumors present massively. I'd say the base rate would suggest that there's some kind of stromal tumor or connective tissue tumor, the most morbid of which is a sarcoma. I yesterday had a patient who had a gastrointestinal stromal tumor who had a 15-centimeter stomach mass, as an example. I think the most common epithelial tumor to present with such a large such a large size as ovarian cancer, simply because it has so much room to grow in the retroperitoneum and has so much time to grow because it hides. So when you see a cancer this large, I think you're thinking that it's a cancer of the connective tissue. And so I've seen mesotheliomas do this, sarcomas do this, gastrointestinal stromas do this. But you're right that there is some hope for the patient that this might not be a very aggressive malignant process and it might be an infection. I think the infections that you'd entertain in this circumstance are a subset of granulomatous infections, which you already outlined. I think there are probably two exceptions to the word granuloma here, and that's actinomycosis, a filamentous organism. But also the rare entity not relevant to this patient was echinococcus. So there's a couple of types of echinococcus that it's called alveolar echinococcus, which can take over the patient's body in a tumor-like fashion. I think what we've learned, Lera, is that this mass seems to originate in the mediastinum. So the hypothesis that something exogenous was introduced in the trauma is less likely. And instead, I think you ask yourself, well, what kinds of infections are plausible now when the external trauma is not there? And I think the apical fibrosis that he has in his lungs is intriguing and may represent a granulomatous infection that you are already invoking. And I'm really curious about a very interesting possibility because this mass is on the right side. And it overlaps with what you've discussed, the entity of fibrosing mediastinitis, which is a chronic fibrosing condition, which usually doesn't cause such invasive features, but is a manifestation of how the infections that you already alluded to can take up space. And the vast majority of them, curiously, are right-sided. And so I'm just so intrigued by the fact that this is on the right side and has seemed to have spared the left side. Yeah, I think we could also analyze what it means that there's local regional lymphadenopathy. The fact that it's spread to the axilla um, uh, is very, very interesting. But yeah, I think I've never seen anything like this. But I think the ultimate answer will be tissue is the issue. And I'm curious what you're thinking about how you might practically proceed with getting this patient an answer. What do you think you would do?
Yeah, I think that there are a lot of sites that we can biopsy from, and I would be talking potentially to the people who are gonna do the biopsy, whether it's safer to go from outside, so from the skin side, or try to go and take the piece of the mass from the inside, from the mediastinum itself, like potentially transbronchial biopsy. And also, I would want to potentially make a sense of lymphadenopathy that we're having here, because potentially if something is invading the mediastinum of the patient, the same process is invading the lymph nodes of this patient, and by doing excisional biopsy of axillary lymph node would be a safer option for this patient, potentially.
That's superb. I have nothing to add. I completely agree. Can you imagine a way serologically or through blood-based tests that you can gain a lot of momentum? Maybe not an answer, but any blood-based clue can elucidate this case for you?
Yeah, I think I would be going through differential for mediastinal masses that we have, so potentially um, entertaining the possibility of lymphoma, so potentially like checking the LDH level of this patient. Also understanding that this could be also germ cell tumor, so I'm not sure if it could present this way with like local aggressiveness without early metastatic process, but I think checking beta HCG, alpha fetoprotein would be also helpful here. Yeah.
Perfect. I love it. I'm on the same page with you. Yeah, Alec, what did y'all do? What happened?
Okay, yeah. So I went back to examine the patient and did note some axillary lymphadenopathy that we saw on the CT, but no significant inguinal or cervical lymphadenopathy. I did a general exam, which was normal. We did do an ultrasound of the scrotum with Doppler, which was negative. Just like Lyra had wanted, we did an AFP, a beta HCG, and a TSH/T4. All of that was normal. We had a ferritin, which was 600, a vitamin B12, which was 200, which is low for our lab. Had an LDH of 442, normal being less than 270 for our lab. The uric acid was 8.1, no prior to compare to. Had a SPEP with immunofixation, which was normal, and also urinalysis without blood or protein. And I'm going to stop here, and the next Alcott will reveal the diagnosis.
Fascinating. All right, Lyra, what are you thinking?
Yeah, I think the germ cell tumors are definitely lower in the list right now. And the highest concern with the high LDH and high uric acid is potentially a lymphoma, but also remembering the last case that I discussed of neuroendocrine tumor that can also present with very rapid cell turnover and even cause tumor lysis syndrome without provoking chemotherapy. With the high uric acid, I would potentially also be keeping that diagnosis in the back of my mind.
Yeah, I think it's interesting how this changes the calculus, and I am right there with you that I think many germ cell tumors have positive tumor markers. Just emphasize one aspect, there is one germ cell tumor that I think was on your mind already that characteristically doesn't have any positive tumor markers, and that's teratoma. So you're right that some germ cell tumors are reduced by this, but a large not large, I don't know it to be large, but a calcific mediastinal mass prompting a germ cell tumor with negative tumor markers would still keep teratoma as a possibility. And I think, as you're saying, the amount of turnover that this tumor is having seems to be high based on the LDH and the uric acid. I think what this case illustrates to you is that serological assessment in most instances can push you further, but ultimately tissue is the issue. So, yeah, I think everything that you mentioned is still fair game. Um, yeah, I don't think I have anything wise to add apart from whatever this is will be very illuminating for me. I've never quite seen a case like this, and I'm really eager to see what of the many things that I think you and I are entertaining, what this turns out to be.
Okay, amazing discussions. Yeah, I also had never seen anything like this and have never seen anything like this since. So we did a core biopsy of the left axillary lymph node and then also of the mediastinal mass. And that showed plasma cells with kappa light chain restriction that were EBV negative. All the cultures were negative. The flow cytometry from the mass was also negative. The serum free light chains came back, and the kappa level was 2,000 milligrams per liter. And the lambda was 16, so that with a ratio of greater than 100. The beta 2 microglobulin was 5.9. Normal is less than 1.8. And then we did a UPEP, which showed 2,100 milligrams of protein with an M spike of 51% without a heavy chain. So the patient was ultimately diagnosed with a plasmacytoma with light chain multiple myeloma. And just to share some reflections, so I think like Lera and Rabih had really commented on, it was really tough to try and figure out if this started in the bone on the outside and invaded into the mediastinum, or started in the mediastinum and radiated out. And based off radiology's description, I was sort of thinking about this primarily as a mediastinal mass that had spread. And the internal calcifications were very interesting. It's not something you typically associate with, myeloma or plasmacytomas. And I thought this was going to be a sarcoma almost for certain. Even when I plugged this into ChatGPT, that's what it said. And I think doing some further reading, it sounds like that amyloid deposition, if it's chronic over time, can actually lead to calcifications and mimic the CT appearance of a sarcoma, in particular a chondrosarcoma. But other masses that can cause calcification in the medium stinum include lymphoma, but typically treated lymphoma, metastatic adenocarcinoma, some thymomas, particularly if malignant, and then granulomas, infections, and teratomas, as you all had mentioned. But it was an extremely humbling case about thinking about the mass was so destructive, it was impossible to know where it had begun. Whereas if we had caught it earlier and thought of it more as a bone lesion that had spread further inside, I think that would have helped us elucidate things a little bit further. And then, as Rabih had noted about this, the weight loss was more a profound clue. The dysphagia ended up being more noise than anything. He was able to eat fine. He had just lived with the consequences of this, and due to some sort of difficult social circumstances and just some distrust of the health system, he ultimately hasn't been able to follow up with care. And I think that speaks to like how big the mass was before he showed up. So sad in its own way, but a very elucidating case. And I appreciate you guys taking the time to discuss it. And I think you did an awesome job. And I'd love to hear your reflections.
My mic keeps changing. I just wanted to thank you. I think this case illustrates so many powerful clinical reasoning principles that are really, I think, bread and butter to what we do. Ultimately, I think that short of getting the serum free light chains, it's probably impossible to crack. But I think that is such a powerful point of the value of a small number of tumor markers. And for me, the two Ps, the PSA and the paraprotein analysis, are the only two tumor markers that have ever really radically changed our approach. And so it's really cool to see just how powerful that this paraprotein skews this case. I'm really curious, Alex. So, and my current understanding of a plasmacytoma is that you have to have a paraprotein. And so the bone lesion plus a paraprotein equals a plasmacytoma. Can you remind me how you incorporated the multiple myeloma aspect as part of the diagnosis? What additional data did you get that incorporated that part of the diagnosis?
Yeah, ultimately the patient would have benefited from a bone marrow biopsy, but the path came back later. But it was a serum-free light chain ratio over 100.
Oh, that's right.
Plus the plasmacytoma, and then he had some anemia as well, and with the proteinuria that was felt to have met criteria for myeloma.
Yeah, I forgot. Thank you for reminding us all that essentially whenever you have a serum free light chain ratio over 100, that is equivalent to a bone marrow. Amazing. Lera, what are your reflections?
Yeah, I think just the presentation of the disease causing very, very aggressive local process, but yet keeping so silent on the periphery with causing just mild anemia and getting some noise on more like advanced labs, I was thinking, could we diagnose the patient sooner? And I couldn't find a way to do so because there is no indication for renal dysfunction, no evidence outside anywhere else in the dysfunction of other organs. And yeah, this is a really, really sneaky diagnosis, I think. Yeah. Kudos to you, Alec.
I'm going to share a story with you all later that illustrates the principle of, even if you've seen something and you've learned something, you have to see it like 10 times to fully upload it. But Alec, I have a journey that is much less emphatic than yours that you just shared today that illustrates some of the key principles that I think you taught us today that I'll present to you all in the Academy session soon. It really just sparked that reminder. I'm curious, I'll just ask you one other question. When in your care of this patient did the serum free light chain analysis come back? Did it come back before or after the biopsy? And I'm curious how that piece of information kind of changed your calculus.
Yeah, so I was not expecting that at all. I had sent the we had sent the SPEP, and that comes back pretty quickly. But I personally hadn't done I think we had sent the UPEP and the serum free light change just as like, oh, we'll just be thorough or whatever, but they had not come back. So the biopsy, the patient got the biopsy and it was discharged actually.
I see.
And then the biopsy came back and then the serum free light chains, and the urine had come back. And, I called the patient, told them about the diagnosis and, unfortunately it hasn't been able to follow up quite yet, but this was not something I was expecting. I was very much framing this as a case of a mediastinal or sort of soft tissue out versus, bone in. And the internal calcifications, like I think I leaned into that a little bit too much. And I posted a link to a paper in the chat that sort of describes this phenomenon previously. But very humbling case. I've never seen a plasmacytoma that large and that destructive. Most of the plasmacytomas I've seen have been in the spine. And usually when they grow, people have significant, compressive symptoms related to that. And he has just been able to adjust to this for years. There is some association with plasmacytomas with trauma. There isn't a lot of evidence to say that they're causative, but prior traumatic sites can be, potentially provide a milieu for growth of pathologic lesions. But it's there's no direct causation with that. So, like you had mentioned, the trauma was probably his interpretation of like something that was more sinister, unfortunately. But yeah, just an extremely humbling case all around, and learned a lot from you guys. Thanks for discussing.
Oh, thank you for presenting it. Lyra, is such a treat to go discuss with you. And yeah, there's a lot of learning to be had. Thank you. Thank you both. Zachariah, Mike, to you for the teaching points.
Absolutely fantastic case, and there's a lot to offer in terms of clinical reasoning. As Rabih alluded to earlier, a lot of bread and butter, thinking through the problem, defining the problem. We started off with a fascinating story of 60-year-old gentleman who had fell 5 years prior onto his chest wall and then had this mass. And then Rabih quite cleverly taught us later on that we should think of 3 C's when we faced with something like this, because the patient then 5 years later presented with this mass, and it could be one of the 3 C's, which is that either it was causal, the disease then coexisted, or it was simply a coincidence that he had fell that 5 years prior. And then Lera beautifully took us through an approach to thinking through chest wall masses. And that's an anatomical approach. You can use the outside in or inside out, thinking of all the structures that come along the path, whether it be the skin, the muscle, vascular structures, and the lung. Also think of complications and incorporate that into your clinical reasoning, whether it be a mass effect, airway compromise, as was clear in this case that partial or most of the trachea was compressed, vascular compression, as was evident from the case as well, with some collateral flow. And then when we think of orthopnea, Lera again took us beautifully again through when thinking through orthopnea, where base rate of disease tells you that it's LV dysfunction, and if not LV dysfunction, think of something that is impairing the diaphragm's function, either from below, whether it be abdominal, an abdominal mass, ascites, or something from the chest, or diaphragmatic weakness itself that can, and in the space of orthopnea plus the chest mass, possibly think of some systemic complications. And then thinking through weight loss, again, clinical reasoning, again, base-native disease, think of systemic disease or local disease in the GI tract, where proximal more often not than distal disease. And again, thinking of incorporating the overlap between cancer and weight loss, either that it would point to metastatic disease or specifically, again, involvement of the upper GI tract. And there are some exceptions. And then thinking through how would the best imaging, how would we best visualize a mediastinal mass, and best form of imaging would be a CT with contrast. And when we faced with a large mass, especially particularly of the size that we were faced in this case, always exclude malignancy extensively and then consider other causes, infective, inflammatory, autoimmune. And then when thinking through anterior or mediastinal masses in general, think of the T's. And then with regards to solid tumors and some slightly elevated uric acid, always try to exclude tumor lysis syndrome. And as Rabih alluded to, more often than not in these cases, tissue is always the issue, to better look at the tissue, to give us not only the tissue, also some markers. Thank you, Alec, for a very well presented and well all round actually fantastic reasoning by Lera, fantastic discussion by Rabih.
My gosh, I hope you will narrate us through the Cape Town Marathon in 2026. That was absolutely incredible. Thanks to Zakaria G for scribing. Lera, you were absolutely outstanding as per usual. And Alec, a big, big thank you for a really, really educational case. See you guys later.